Audio recording for this meeting has begun.
Good afternoon, everyone, and thank you for joining us for Et al., the NCSD Journal Club. My name is Leandra Lacey, and I'm the Capacity Building Manager for the National Coalition of STD Directors. My hope is that this Journal Club will not only help to keep you abreast of current STD literature, but also that you can utilize the findings from the articles presented and apply them to your own STD programs, whether it's in regards to STD surveillance, diagnostics, treatment, partner services, or outreach to the populations that you serve. This is just a reminder that this webinar is being recorded, and the recording will be made available after the presentation within the week. If you are not speaking, I ask that your phone line or computer speaker is muted just to avoid background noise. And if you have questions or need technical assistance during this call, please utilize the chat function in the bottom right corner of your screen. All questions will be addressed at the end, but we'll keep a queue, so please send them our way via the chat box as they come up. And I also want to flag for you that there's a box called Files on your screen. It's in the middle of attendees in the chat box. And in this box, you'll find the journal article that's being presented on, so you can download it and reference it. So for our agenda today, we'll start with a brief introduction of our presenters. We'll then move into the article background, methods, and results. And then there will be a time for discussion and engagement with the presenters and also with you all as participants. There will also be ample time for questions at the end, as I mentioned. So speaking today will be Dr. Jennifer Clifton and Aaron Prado. Dr. Clifton has been faculty for the University of Utah College of Nursing since 2005. This role combines graduate student instruction, client care in a juvenile detention center, and clinical management as director of 7 juvenile justice clinics. She earned her BSN at Indiana University, MSN/FNP at Brigham Young University, and her Doctor of Nursing practice at the University of Utah. Dr. Clifton is a certified correctional health professional and a certified nurse educator. She is also the incoming co-chair of the Utah Trafficking in Persons Task Force Juvenile Subcommittee and an active participant in the UTIP Medical Subcommittee. Dr. Clifton is a member of the National Commission on Correctional Health Juvenile Committee and an NCCHC board member. Aaron Prado has been with the Utah Department of Health for the past 10 years, serving in multiple roles including health program specialist, integrated testing coordinator, program manager, and currently prevention, treatment, and care technical advisor. Aaron holds a Master of Science degree in health promotion and education and is a certified health education specialist. In her spare time, she enjoys camping and hiking in Utah's beautiful mountains and spending time with her family. Today, they'll be highlighting an article Dr. Clifton wrote in a recent issue of the Journal of Pediatric Healthcare around screening for chlamydia, gonorrhea, and high-risk sexual behaviors in Utah's juvenile justice system. My hope is that you'll be able to use implications from this work to inform work that you may be doing in correctional settings where you are. So without further ado, I'll go ahead and hand it over to Aaron and Dr. Clifton.
Thank you, Leandra. I appreciate being invited to speak today and talk about this article. This is a big project that Aaron and I have been working on for a number of years, and it's exciting to be able to share it with you all. So I am going to start by going ahead and giving you a little bit of background. I know I'm preaching to the choir here, but chlamydia is one of the most commonly notifiable disease in America and in Utah. And 2/3 of the cases in Utah of chlamydia are between 15 and 24 years of age. So we, in our juvenile justice setting, we see youth from the age of about 12 to 20. So these are our kids. And we don't have a huge high rate of gonorrhea, but we are concerned about that too because of the rising prevalence, drug resistance, sequelae, that type of thing. This also, nationally, when you look at the data, people in detention facilities, jails, prisons, secure facilities have a higher rate than their counterparts that are in the community. So that, again, nothing super shocking for you guys here. But what surprised us is that Utah did not have funds set aside for the screening for youth. Before we had a grant together, we had small grants that would pay for screening for gonorrhea and chlamydia, and those really dried up. And so we started just doing it as part of our practice and got pushback because there was not money set aside for that type of screening. So that's where Erin and I collaborated on a 12-month screening for gonorrhea, chlamydia. We also screened for HIV and hepatitis. So based on that screening, we were able to get some data, and we were able to present it to the state legislature that set aside the money for this screening. So in March of 15, we were appropriated that funding. It was through the state legislature. It was an appropriation. It was not a bill, and the appropriation is a one-line statement that says screening for sexually transmitted and juvenile justice services. So it really gives us a lot of latitude as to what kind of screening we want to do and who we want to screen. We had 2 one-year appropriations. Each year I had to go back to this, the legislative body, present our data, and then in 17, I believe it was, we got ongoing funding. I still send them all my data at least annually, but I don't have to go beg for the money any longer. So that's the background on where we are. And when we got this money, we had, like I said, a lot of latitude as to how to spend it. So what we did is we worked with an epidemiologist through the Department of Health, and really through their guidance decided to focus on gonorrhea and chlamydia screening. And additionally, we started out, we do just the youth in juvenile justice that are actually incarcerated in correctional facilities. That accounts for about 1/3 of all the youth in the juvenile justice services. The other 2/3 are out in the community on parole. So it's a relatively small number, but that's where we decided to start, because that is where we practice, and so that we could establish nursing care, nurse practitioner care, and then the connection with the health department.
Great, and this is Erin speaking now. I just want to give you guys a little bit of background more about how this partnership really started. So in 2011, Dr. Clifton's boss, the Associate Dean of Faculty, approached the Department of Health asking for money. I think, in Utah we don't have state funds. There were no funds appropriated previous to 2015, like Dr. Clifton mentioned. So really we established that connection right there. We didn't have any funding at that time to give to the College of Nursing or to JJS for screening, but the Department of Health really recognized the need to do this. Then in 2012, we had an opportunity to write for additional funding through PS 12-1201, which was the HIV prevention grant. It was called Category C, and this conversation was fresh in our mind of how our youth in correctional facilities were not getting screened for chlamydia, gonorrhea, or HIV or hepatitis. So we actually wrote that into our application. We were funded, and like Dr. Clifton said, 12 months we did a screening project. Fortunately or unfortunately, we didn't identify any HIV and we didn't identify any hepatitis, but we found a lot of chlamydia as expected. So I think really, the main message here is to consider that integration. Even though it was HIV funding, the biggest part of the project was really all about STDs. So we really emphasize program collaboration and service integration. That is my favorite mantra. I always
I always speak that whenever we're doing any sort of grant application or integration with other services is to really figure out how to leverage resources and then making that resource partnership with the College of Nursing. 7 years later, it's still such a meaningful project and so many youth lives have been impacted by Dr. Clifton's work. I think keeping that in mind is really important. And then a little bit more about Utah's epidemiology. Like Dr. Clifton said, chlamydia, #1 reportable disease. We are technically, Utah is a low morbidity jurisdiction, but we still have a lot of chlamydia. And in the age group that is being served by JJS, we have 16%. That's the 16% of Utah's population is age 15 to 24. However, that is our highest burden age group for these infections. So you can see on the slide 60% of chlamydia and 33% of gonorrhea cases are in this population. So really identifying an opportunity to provide an intervention is crucial. This age group, as you all probably know, has increased risky sexual behavior, anatomical vulnerabilities, and we need to increase the screening. So the positivity is about 11%. So positive chlamydia gonorrhea test for youth sent from a juvenile correction center accounts for 11% of all of the cases in that age group last year.
So I wanted to follow up and just give you a little bit more background and explain that this really was not a novel idea or anything we did rogue. And if you decide that this is something you want to do, I want you to understand that you have the backing of some very powerful organizations. First and foremost is the Center for Disease Control and Prevention. And this is a quote. These are quotes from them, and they are cited at the end of the reference in case you would want to use those. But they absolutely do recommend that people in corrections are screened on intake. So that was the first and foremost organization that we would cite. And then being medical professionals with pediatrics, we went to the American Association of Pediatrics for guidance. And these are really the people that set the guidelines too, along with the CDC, for how we practice as practitioners. They set the guidelines for pediatricians around the country as well. And they endorse STI screening for infectious diseases among adolescents. And this is, although I didn't put it in here, they're talking about, this quote comes from an article solely addressing youth in corrections. And then there's the National Commission on Correctional Health Care. This group sets the standards for medical care of people in corrections throughout the nation. And they too recommend that that youth are screened upon admission. So we really have all these people that are telling us how we need to be practicing, and we are really just doing this to follow standard of care or best practices, and we have these people to back us up. So I would recommend reading all these articles for citation if you decide to move forward and really try to work on this. These are the people that you need to cite as evidence that this is needed. So really when we started out, the purpose, we had multiple purposes for this. You can see we wanted it to be one-on-one time with the nurse and the youth. This was initially meant to be a screening that the nurse would ask the questions of the youth and would answer any questions that they had. Also, we wanted to set up an efficient data collection. As I said before, we had been doing screening off and on through some small grants, but we hadn't ever had our data segregated out from the general population. Like when we went with Planned Parenthood could not tell us our positivity rate of our youth. And so we really wanted to learn that. And as someone working in corrections, there are not a lot of university corrections collaborations, and that's really where you're going to get most of your data. Otherwise, this is just really not collected. There are people who are screening for this in multiple correctional facilities around the country, but there is not a lot of strong data as to specific to their population. And of course, we wanted to diagnose asymptomatic infections among these youth and then treat them. And we can do that confidentially and on-site because of our staffing situation. All our clinics are managed and run by nurse practitioners, so we have standing orders. But the nurses still notify us when they have a positive, and we write the orders for the screening after looking at the allergies. And we are doing this on a statewide basis. Just so you understand that too, these are not youth that I necessarily will see directly. We have a 5-hour drive to southern Utah and a 2-hour drive to northern Utah. So we are statewide in our scope, and it can be done. We want to decrease the prevalence of gonorrhea and chlamydia and really learn about, the other thing is we really wanted to learn about the distribution of CDC-designated high-risk behaviors. And then we wanted to obtain ongoing funding. In learning about the high-risk behaviors was a little complicated, and I'll explain on that in just a second. So when we initially started, another thing that they don't collect is how many individuals come into corrections. We know how many admissions there are, but we didn't know how many unique individuals there were. So we didn't know how we were going to be screening those people. Additionally, we have people coming in rapid readmissions. Okay, so we would have the same person in maybe 4 or 5 times in 1 month. Well, do we screen each one of those every time they come in? And so we had to set up parameters, and so that's where the high-risk behaviors became really a building block for this project. Because at first we just said we cannot screen everybody. We can only screen those we will screen every girl because of the risk of complications, but we will only screen the sexually active boys or the boys who have participated in one of the high-risk behaviors. So that's where that came from and why we were really focusing on the high-risk behaviors. Eventually, we realized that we had enough funding that we were able to screen everybody that came in. And so the high-risk behavior questions became less crucial for screening. However, we now take the data from those questions and we use those more to guide teaching, to education and interventional programs. So when we started off, we created 6 hypotheses, and you can see them here. We thought that our correctional system would have, the youth in our correctional system would mirror, we would have 60% positivity rate of the national in corrections. But like I said, the data in corrections is not good. We thought that the older youth would have a higher rate. We hypothesized that the urban youth would have a higher rate of infection, and those who use condoms would have a lower rate. Females would have a higher rate. All things that we thought that would be expected. And so again, our method was a verbal screening tool. We did the one-on-one screening, and so we would screen everybody that walked in. Urine screening was done on, like I said, all the females, unless we would only screen any one individual once every 3 months. And we did that based upon CDC recommendations for HIV, men having sex with men. They recommended screening once every 3 months at the time. So that's what we went with. We figured that was the highest rate, just the highest risk category that there was. And so the most any one person can be screened is every 3 months. And again, if they're treated, then it's 3 months from the treatment date, or if they're negative and they're not treated, it's 3 months from the screening date. And this is where we do the urine screening, like I said, on the males who had sex with 2 or more people or who answered yes to the high-risk questions. And so these were our results from our first year out. We were very pleased to see that the people that there was a statistically significant difference between the youth who even sometimes and always used a condom as opposed to those who stated they did not, because this is all self-reported. And so that was very encouraging news there. And we use that to teach the youth. And then as far as our risky behaviors, we went with a partner not well known, intercourse that was forced, and intercourse for drugs, money, or something you need. And part of the reason why these were chosen too is these were areas where we felt we could make a difference, we could really address it. We don't do a lot as far as detox, and so talking about sex while high, we didn't want to go there. So these were our 3 activities that we identified that would have been the high risk, that if a male would have participated in just one of these one time, then that person would have gotten screened. And so, we have seen, 22% right off the bat having sex with someone that was not well known. So we have had students go in talking about the risks and dangers of that. The intercourse that was forced, intercourse for drugs, money, or something we need, we have referred all those to the proper legal channels, the DCFS. And intercourse for drugs, money, or something you need really is the definition of human trafficking. So that's where we have begun being active in the human trafficking arena, because we've identified anywhere between 3 and 4% of our youth in any given quarter stay positive for trafficking. So these are the results. We had 162 positive out of nearly 2,000. These are our rates among the males and females. And we had a 90% treatment rate, and I'm going to talk about why that's not 100% here in just a bit. Erin?
Great, thank you. This is a great segue. So just a little bit of background. Until this year, Utah's public health system was investigating chlamydia as well as gonorrhea. Now we're no longer going to be investigating chlamydia, but really this partnership was crucial to getting these kids treated and educated. So like Dr. Clifton said, they had a 90% treatment rate. 57% of these cases were not interviewed by public health between 2012 and 2018. There was a huge disconnect in contact information, public health being able to contact these kids, parents not consenting to hand the phone over for interview and things like that. So really this partnership was why these kids were able to get treated and educated. Their treatment rate has stayed at a minimum of 78%, and not treated has stayed under 21%. So you can see there in the graph the treatment rates. The treatment rates are very high for this transient, difficult population, and I attribute that to this partnership.
So, like Erin was saying, the barriers to treatment really are the rapid turnaround of the youth and them being a highly transient population. Our turnaround for our screening time is about 7 days, and that is also about the average length of stay of youth in the juvenile justice service. So if there is any delay in getting the urine out, or if a youth is in shorter than an average time, then we're not able to treat them on site. We're hoping we can sometime soon get a rapid screen for this, but we do not have that at this point. But we have done some things, some workarounds. First of all, the nurses initially, we gave them a mailer that would hold about 10 specimens in it. And we have some clinics that are quite small, and it may take them 2 or 3 weeks to fill that container. And they wanted, their focus was on saving money. And once we explained to them that we really needed to get these specimens in more quickly, we didn't care even if they just shipped one at a time. We had the funding that paid for that. Again, this was not charged to the facility. This was part of the funding that we had, that we wanted that urine as soon as possible. So once we were able to convince the nurses, that was a big barrier initially. Also, we started asking if the youth would give us more information, a confidential phone number at the time of screening so that we could potentially reach them, because we had phone numbers for the parents being in corrections. We had other phone numbers, but we didn't necessarily have the youth's permission to call those, and they were not always kept up to date. So oftentimes we would get a friend, an aunt, somebody that they would give us permission to call to get in touch with them. So that was huge too, and we did not provide that phone number to anybody else in corrections. It was just to be used for this purpose. And additionally, we are a system of 16 different facilities throughout the state of Utah. Like I said, we spread from the far north to the far south of our state, which is about an 8-hour drive. And going west to east is about 3 hours. So we've got a large area here. But these youth tend to stay in the juvenile justice system. They may move from one type of facility to another, or they are transient population. So we created a watch list for youth that were released without being treated. And then when that youth showed up at another facility, was arrested somewhere else in the state, that nurse could immediately treat that kid and not have to go through the whole process again. And both of those, or all three of those actions, have really increased our treatment rates, because we started off right around the 60 percentile, and then it went as high as 90, and like Erin was saying, it's right around 70 right now. So we feel like we have about as good of a handle on it as we can at this point, as far as the turnaround for screening, but that was a huge barrier. Another barrier that I did not list here, but is something that needs to be considered if you're going to do this, is that when you're working with corrections, the health, especially the health screening for an infection that is not readily apparent, is not a priority. It is a different mentality than we are used to working with in health department and medical communities. And so really working with them closely so that they understand the sequelae that can happen and the legal liability that they have for these youth is absolutely crucial. And again, it helps to take in the explaining the different groups too that back this, and explaining that this is a national standard, because that really can be a barrier, is the understanding of the staff and how you're going to set up the screening and their cooperation in this. So it really, like Erin keeps saying, it really is about communication and really making friends and letting them know that they can contact you with questions and concerns to keep this program going. And it's an ongoing, it is an ongoing effort, because again, screening for an infection that is not readily apparent is not necessarily the priority when these kids come in having committed the crimes they have and in the state that they have. But we are there to be their advocates for this. So the results of our hypotheses was that the females, we had, our females were well above that national 60% rate. So we were surprised at that, and the other ones, the males, were well below. So that national rate that was posted through the CDC was not really a guideline for us at all, and we did not meet that expectation. So I hope you understand what I'm talking about when I'm talking about this, that we were not able to use the data that was posted nationally really as much of a guide for what we actually saw in our clinics. And then the other ones were all supported. The younger youth had a lower rate. And the urban youth did have a higher rate, although initially in our first year, initially in the first few months, they really looked like they were about the same. However, as we collected more urine and we progressed in this, we saw that the urban youth did have a higher rate. The females have a higher rate of infection than the males. But sometimes that can really skew your numbers because in corrections, the females make up a small proportion of people. So you've got to keep that in mind when you're looking at these numbers. The youth who use the condoms, like we talked about before, had a lower rate of infection, and the youth with the high-risk behaviors. Those were identified as truly high-risk behaviors in our group. And so some of the limitations of this study, or this project initially on the article that you read about, was that, again, that we put those screening parameters on the males that came into the facility. We have, again, since opened up to everybody, but we felt like if a male said he was not sexually active, that he was just telling the truth, basically. And so we went with that, where we didn't trust as much the females. And again, we didn't know what the costs were going to be. And initially, we had two different data collection methods were used. Some of the facilities, despite the fact we really wanted this to be a one-on-one time, did not have enough nursing hours in their correctional facilities to support this. And so we ended up having to make up a form, and the kids in the rural facilities, the smaller ones, ended up self-reporting, where initially the kids in the urban facilities were being questioned by the nurses. We have since then changed our process, and it is all self-reporting. And so, but then the nurse reviews what the youth has written down, and we'll talk to them after that. And so that may be right away in urban facilities where the youth turn over quickly and where we have so many, or it may be a few days out in the rural facilities where they have less nursing hours, and it would be when the nurse would come in to see them. And then, again, we only screened for urine. We did not do any oral or anal swabs as far as screening for gonorrhea and chlamydia. It was a huge barrier trying to convince people that we needed to get urine samples. Again, we were talking with corrections. You are not talking to people in the healthcare field. They found this to be very invasive, as it was with the urine, and did not honestly believe that there were gonorrhea and chlamydia problems with their youth. And so just getting the urine was a huge hurdle in a conservative state like Utah. It may not be in your region, and hopefully it's not as much there, but we ended up limiting it to urine-only specimens. And these are some results I just wanted to share with you. These are 3 years of results. They are not published yet. They're going to be presented at the Society for Adolescent Health and Medicine in 2019, but they were not part of this article. But this is a bigger picture than what we were able to report in our article. These are 5,000 youth by now that we have screened, and as of June 30th of 2018 is when this closed. So you can see we still have some work to do, and our numbers are still staying right around the same for the domestic minor sex trafficking, about 8% for the forced sex. We're not making a big difference yet on the condom use, although the youth are anecdotally telling us that they are learning something. And then of the urine screens, we're still having a high positivity rate. We had, the last time I looked, it looked like about 85%, or when we did this analysis over these 3 years. And we work closely with the health department. Not only do we look for kids that are released within the juvenile justice system, but we communicate with them so that the health department contacts the youth even when they are out of the juvenile justice facility. And Erin can talk to you more about that piece of it. Clinical implications, of course, we're hoping to decrease the burden of gonorrhea and chlamydia among these youth. We're hoping to have a chance to educate the youth and to treat them. And it really has this project has really been a catalyst for a lot of good conversations with our youth, a lot of education that the nurses tell me would not have taken place otherwise. And we're also identifying these high-risk behaviors, and we are working on programs that will support education among these youth, particularly, like I said, within the sex trafficking, but also reporting a lot more forced sex or rape among this population that we simply were not screening for before.
So as Dr. Clifton mentioned, really making friends is such a key piece. The nurses are interacting with these youth on a different level than public health had ever done before, and also making friends within our organization. So really making the connection between public health and the clinicians and the providers that are providing services to these kids. Before we had conversations 7 years ago, we didn't know what nurses to call. We would call the correctional facility and go down the phone tree trying to get to somebody who knew what was going on with these kids if we needed to work on treatment or any other public health initiative. So really the relationship between College of Nursing, JJS, and the Utah Department of Health has been so valuable. Sharing resources, public health pricing, that might make sense for your jurisdiction, it might not, but just sharing those resources and connecting individuals together. And even though we don't currently have federal grant funds to support the testing, we make sure that the College of Nursing knows that the Department of Health is very grateful and supportive of their public health efforts. We have recently granted them 340B covered entity, so they can now access treatment at that 340B price. We provide in-kind support, which we recognize that the College of Nursing really is providing a public health function in the STD realm. They are doing the same grant goals without any funding, so they definitely qualify as a STD 340B covered entity. And when this project first started, one of the things Dr. Clifton mentioned is that the staff really could benefit from some sexual history education. So we came and did an in-service for all the staff about how to take a sexual history. We did some role plays on how to get comfortable asking these hard questions. We talked about terminology. We talked about slang terms, just really bringing everybody into our world. Like Dr. Clifton said, these are correctional facilities that we're talking about, so really educating the medical providers about that. And so the medical providers can also work within that correctional setting and maybe share some of that knowledge and attitudes with the correctional facility. And then maybe one of the most important pieces out of this whole project is that now there's a link between public health and this population. We now know who to call. We have phone lists. We have a personal relationship between public health and the medical providers that are seeing this really vulnerable population.
So the way we see our next steps are moving beyond the youth in the juvenile justice system to those who are out in the JJS system but out in the community. There are some barriers to that in that getting the youth to come in to be screened and then also getting treatment. And we are working on both of those right now. one of our solutions is to hold a clinic where a nurse would go to the social worker's office, and the social workers would have the youth in the community come in, offer this free screening, and go from there. We're also working, again, with national and local experts to create youth-based centric interventions. We're able to do hot spotting on the data we've collected, so we can see exactly where which clinics have the highest rate of forced sex, which ones have the highest rate of human trafficking, and really able to target our interventions that way. We can even go down, to the level of Hispanic females, or whatever group may be the most vulnerable and target our intervention specifically for something that would work with that community that is ethnocentric. And we are able to let's see, we are working to further develop questions that learn more specifics about the behaviors that they're doing. And that really has to do with trafficking, as far as, are they being asked to pose for pictures? Are they what exactly are they trading sex for? Are they dancing in clubs? Is this an organized thing, or get a little bit more information beyond simply, are you exchanging money for drugs or something you need? Why are you doing that? A hugely vulnerable population are the homeless youth. And we've really been able to tailor a lot of our interventions towards being able to go out and work to get them specifically resources, and making people aware in our community that this is a very vulnerable population. The homeless and the LGBTQ youth in our facilities, we have found, have the highest rate of human trafficking. So again, we try to tailor our interventions to the specific needs of those communities. And these are our references. And then we are happy to take questions.
Yes, thank you so much, Dr. Clifton and Erin. You did a wonderful job of kind of laying out this project, giving us the background, and then it's very interesting hearing about the next steps as well, and just lessons learned from this project as it continues. So we're definitely going to open it up now for questions. Feel free to type your question into the chat box for our presenters, or you can speak on the phone line as well. That's also an option. It's up to you, but we can open the floor now for any questions for them. And you don't all have to speak at once. It's okay.
Hi, this is Laura from California. Can you hear me?
Yes.
Yes.
Great. Thank you for this great presentation. I know that you mentioned in the beginning that you don't have accurate booking numbers, and out in California we also do a fair amount of screening in juvenile detention. It looks different because in California each jail is run by the local county instead of them being all state run. So every county looks different, and data is hard for us to get as well. But I was wondering, even without those booking numbers to really assess the screening rate, I wonder if you have a sense of how many of the young people that are coming into these facilities get screened. We also, in many of our counties, have a universal screening policy, at least for young women. And it really ranges, the screening rate ranges from 60% up to almost 100%. So just wondering if even without that denominator data, you have a sense of how often the nurses at the facilities are actually able to implement the screening policy.
That's a really good question. It's a bit of a sore point, and it's been a real limitation in the fact that some nurses would embrace it more than others, or they would have turnaround, and the next nurse would not do it if a nurse left the facility. And we absolutely do have a sense. Our goal is that we wanted under 10% of youth to not get screened at all. We range from about the mid-90s down to about 60%, and so and we've had a lot of fluctuation. The way that we've been able to raise the rates in the facilities that are lower is by publishing monthly how many kids came in, and then going with how many urine tests were sent, how many people were eligible, and so we try to use peer pressure, and we send those results out to the people, to not only to the nurses, but to the people that run the facilities, so that they see, gosh, my facility, only 60% of our youth were screened here, and, or we had, more precisely, they'd say something like, oh, we had 25 youth admitted, but for some reason we only sent in 3 urine specimens, and, these youth would have all been eligible. And so then those people pressure their nurses. And so that's how we get around trying to get an increase in participation. But absolutely, it is there's a wide gamut of participation among the nurses, and it just is a constant trying to communicate with them. And then what we have done is once a year we actually go to the facilities to inspect them and really see how their system of collection is run, see what barriers there were. Our first year we did site visits, and we went to one clinic that didn't even have a refrigerator for the urine. I didn't even know how they were doing these collections. And so, we really had to work with the nurses, and it's an ongoing thing. But yes, we do have that data, and I'd be happy to share an example of a report.
Thank you. So Sherry Holloway asked in the chat box, what youth population, for example, college students, homeless youth, juveniles, etc., have the highest number of screenings and positive results? Would you happen to have that information?
I don't, but I can definitely look into that.
Awesome, thank you, and thanks for that question.
And we do know that youth in corrections have a higher rate than the youth in the community, than their counterparts.
Okay. I have a question about, I know you talked about the relationship with the administration over in the juvenile justice system, particularly when it came to extragenital testing and how they thought that was pretty invasive, and so that was kind of a limitation that you were only able to collect urine samples. Has there been any work with convincing the administration and staff there to move more toward collecting extragenital samples? I mean, I'm sure you all, missed some positive results because of that. So I was wondering if there was some kind of movement toward that, especially given the national standard and all this data you have from the CDC and other public health institutions that show that, screening, not just with the urine, is super important with detecting infections. So I was just curious about that.
The last time we did our annual rounds, we dropped that to the people that run the facilities. We actually just dropped that hint that may be down the pike. When we came in and we said, well, things we're going to do is we may expand to the youth beyond those that are incarcerated. We may expand to HIV or syphilis testing. We may expand to extragenital testing, those kind of things, just to plant the seed. And since then, we've gotten a few just emails asking if we're going to do it or asking questions about how why we are going to do it. We've sent out CDC information or information from the health department. And so we're really just kind of still at the planting the seed stage in this game. We're taking baby steps.
The baby steps are definitely important.
And additionally, we do test for that when a youth confides that, you know, that they are having, like, men having sex with men kind of situation. When they say that, that's not a screening. That is just testing for the high-risk behaviors. The same way when they say they use intravenous drugs, then we screen for HIV and Hep C, right? But it's not something that we screen for in the whole population. Does that make sense? I seem to have lost audio.
I can hear you.
Okay. Is there anything else? Any other questions? We would be happy to serve as resources for anyone who's interested in working more closely with corrections. I do have correction connections nationally, and we do go to conferences and present. So we'd be happy to advocate on your behalf in corrections. I would be.
Hi there, it's Leandra. Can you hear me?
Yes.
Yes.
So sorry, our internet just happened to go out on this end. Thank you for continuing the discussion. I'm so sorry. I'm trying to log back on so I can see everything on my end. Perfect. Okay, I can see things now. Was the question addressed about the risk survey? I'm so sorry.
About no, what's that?
Oh, in the chat box, Jennifer Harmon asked, would the speakers be willing to share the risk survey they developed?
Oh, absolutely. Yeah.
Perfect. Great. So Jennifer, thanks for that question. I'll definitely, once I gather that information, I'll send it out with the PowerPoint slides and the webinar recording and all of that for those that are registered for the webinar. So you will receive that information. Thanks, y'all. And then there's another question from Jillian. She asked, related to extragenital screening, was there an effort to collect information regarding sex/gender of sex partners?
In our more recent surveys, there is, yes. Initially, I don't know that there was. I think we did. Honestly, I can't remember. But I think we have always asked if it's who they're having sex with, if it's boys, girls, or someone else. I know we are currently doing that. And the other thing is when a youth is admitted to a correctional facility, they get a whole physical exam, which is where we ask them that type of question, which is where we ask them about their drug use. We just did not do that in this screening form, but we do ask that when we do our physical exams, and so that's where we pick up those questions that are not part of this screening.
Thanks for that. Let's see. Any other questions for our presenters? We have about 4 minutes left, so there is a little bit of time for extra questions. Okay. If there aren't any other questions, I have Dr. Clifton's email address as well as Aaron's and also myself. If you have any additional questions that may come up and you want to contact myself directly or contact our presenters directly. And as I mentioned, the recording and the webinar slides and any other information from our presenters that was asked about today, all of that will be sent out via email. And yeah, be on the lookout for the blog related to this article in January. And then the next Journal Club meeting will be in February. So if there aren't any lingering questions, give it a second. There's also before I forget, a evaluation that I would love for you all to fill out as participants. I'll put it in the chat box, but you'll also be redirected to this survey once I close this out, so no worries there. Any lingering questions? Perfect. Well, thank you so much, Dr. Clifton and Aaron. I really appreciate you all taking the time out of what I'm sure is a very busy schedule to present today on this great project. And yeah, I'm definitely looking forward to seeing next steps from you all. Thank you.
Thank you so much.
Thank you for this opportunity,
Happy holidays,
Leandra.
everyone.
Happy holidays.